My name is Josh Baru, and I'm a palliative care physician at Cook County Hospital. Cook County is a safety net hospital in Chicago. About a third of the patients we see on our palliative care service speak limited or no English. As a result, we are frequently forced to work with medical interpreters. Today, I'll be speaking about some of the things we've learned about working with interpreters in palliative care. But this is not a problem that is unique to safety net hospitals. There are 24 million people in America that speak limited or no English. Even if you rarely use interpreters in your practice, many of the skills required for working with patients that have limited English proficiency are relevant to working with people that have limited health literacy. It's fairly clear that for these 24 million people, their language barriers result in significant healthcare disparities, specifically related to access and quality of care. Using trained medical interpreters can effectively mitigate these disparities. To be clear, in this lecture, I will be discussing techniques that are useful for conversations that occur in a palliative care specific setting. Common situations that would be considered relevant to the field of palliative care include communicating about serious illness, for example, speaking with a patient with a low EF, giving bad news like telling a patient they have emphysema, sharing prognosis, or discussing advanced directives. These are difficult conversations that are emotionally charged and value-laden, often for providers as well as patients. As a result, they require unique language and a unique approach. It is for these reasons, more than any other, that using family members as interpreters is not appropriate in the palliative care setting. Family members will likely be trying to support their loved one through intense emotions or coping with their own emotions. To give them the task of interpreting prevents them from being able to fill this role. In addition, we often need to say very difficult things during these conversations. For example, one might have to say to a patient, "You will die from this disease." Asking someone to say these words to their mother is a heavy burden. In fact, it is so heavy that they likely won't translate the words directly. When we layer on the fact that the questions you are asking and the statements you are making may contradict the interpreter's cultural or personal beliefs, one can see how your message might be easily distorted when you use a family member to interpret for you in these difficult conversations. That said, the literature shows that even when we use trained medical interpreters, we don't work with them well. Conversations are shorter, and I see this all the time. People tend to move to closed-ended questions much more quickly when using interpreters, avoiding open-ended exploration. For instance, rather than "tell me about your pain," people say, "Is the pain sharp or dull?" We provide fewer supportive statements, and nonverbal cues are frequently missed or ignored. I commonly see this happening because people are speaking to the interpreter rather than the patient. So, here are some specific tips on working with interpreters. First, when speaking, think sentences, not paragraphs. Using short, simple sentences with frequent pauses relieves a significant burden from the interpreter and likely results in more accurate interpretation. It also allows the patient to follow the conversation more closely. Tip number 2, engage the patient. Speak directly to the patient, maintaining eye contact with them. Use the first person. How are you feeling today? Rather than, how is she feeling today? This may feel unnatural at first, like you're play acting, especially if the patient is speaking to the interpreter rather than you. But it is an incredibly powerful way to build rapport with your patients. It also, as I mentioned earlier, allows you to attend more closely to nonverbal cues from your patient. Now, these are techniques that are essential for success in emotionally intense conversations, as we have in palliative care, but they are incredibly useful anytime you use an interpreter. Now, I have 4 tips that are particularly relevant to the palliative care setting. Tip number 1, brief the interpreter before you start. In palliative situations, conversations are long and they are emotional. The interpreter needs to know what they are getting into and needs to be prepared for it. They might need to arrange coverage. They should also be given an opportunity to opt out, assuming, of course, someone else is available to fill in. You should also use this opportunity to empower the interpreter to let you know if they think the patient is misunderstanding terms that you are using. When briefing, you may also want to address the fact that this conversation may have unusual pacing, different from that which they experience in other medical encounters. The history may be circuitous and may appear at first to lack an agenda. Often in these types of conversations, we spend a lot of time gathering information at the beginning of the discussion, waiting until the end to bring it all together. I would recommend letting the interpreter know this ahead of time, reassuring them that the goal of the conversation will become clear by the end. Tip number 2. The preferred method of interpretation in most clinical settings is for the interpreter to stand behind the patient and to translate simultaneously as you speak. This is how most medical interpreters are trained. However, in a palliative care setting where patients are dealing with a huge symptom burden and may be weak and have difficulty maintaining attention, sequential interpretation, in which you speak and then the interpreter translates what you've just said, is much more effective. It gives the patient the opportunity to hear and process the information at a slower pace. Furthermore, having everyone in the room, including the interpreter, seated in a circle focused on the patient improves rapport and allows for a more open and engaged conversation. Third, remember that your tone and the pace of your speech have as much impact on what your patients hear as the words you use. This is especially true in conversations that are emotional and where you are striving to convey empathy. It is easy to forget this when you are relying on someone else to say your words. Maintaining eye contact with the patient and using the first person, as described before, will help with this. As an aside, all of these rules apply when you are using a remote interpreter, either via phone or video. And in our experience, if you're using a phone, using speakerphone tends to be more effective than handsets. My final tip. For many of the topics that we discuss in palliative care, there aren't any good linguistic equivalents. For some terms, the literal translation is inaccurate. For instance, in Spanish, hospice is often translated as hospicio. This refers most literally to an orphanage or a poorhouse. But in English, hospice refers to a service that is provided to patients, which goes wherever they go, most commonly at home. It's not a place. Other concepts are unique to English, which are misunderstood when translated directly. Power of attorney is one such example. As translated in Spanish, this is often understood to refer to a last will and testament, not specifically healthcare decision-making. The solution, as with patients with low health literacy, is to follow these statements up with a check-in and, if needed, a clarifying statement. Have you heard of hospice? What does it mean to you? As discussed before, empowering your interpreter to provide input or suggestions on word choice during your pre-meeting briefing will also help avoid these pitfalls. And I will repeat for a third time because it is important. Remember that your tone and your intent carry significant weight. Even if you or your interpreter use a word that is upsetting, maybe the translation is harsher than the English equivalent, your tone can often mitigate the impact of this harsher term. In summary, it is never appropriate to use family members as interpreters in the palliative care setting. The conversations are just too emotional. Trained medical interpreters will improve the care you provide. Linguistic and cultural misunderstandings are inevitable. Check in frequently and empower your interpreter to help you. Lastly, nonverbal messages are potent. Speaking directly to your patient, not to the interpreter, will help you attend to these nonverbal communication techniques more naturally. Thank you.